Good afternoon, everyone, and welcome to today's Healthcare Homes webinar. We're so glad you could join us. Today's topic is refugee health in Minnesota, and we're excited to share the insights and resources with you. This session is presented by Lily Rubenstein and Cynthia Trevino, who will guide us through key information about refugee and health in Minnesota. Thank you for being here, so let's get started. Prior to starting the webinar, we will read the Tribal Relations Acknowledgement Statement. Every community owes existence and vitality to generations from around the world who contributed their hopes, dreams, and energy to making the history that led to this moment. In Minnesota, we are standing on the ancestral lands of the Ojibwe, ancestral land of the Dakota people, We want to acknowledge the history of this land, including the Dakota, the Ojibwe, the Ho-Chunk, and the other nations people who called this place home. Native peoples were removed unjustly, and we in this space are beneficiaries of that removal. At MDH, we understand that land is related to health, and we want to be good stewards of the land we are on. This acknowledgement is just one piece of that. We understand that systemic racism, historic trauma, and genocide that has impacted the indigenous communities and peoples in our state. We recognize that land acknowledgement is a first step. We support this action with resources and shared decision-making to meet tribal public health priorities and needs. With our Indigenous neighbors and coworkers, we can advance health equity and work to ensure all communities across the state are thriving and all people have what they need to be healthy. We encourage state employees and the public to research the lands that we are on if you are able, find Native-led events to attend, organizations to support, and causes to champion. Please note that your microphones are muted upon entry. Please put all questions into the chat, and also please note that this webinar is being recorded. One quick Healthcare Homes update is that our YouTube playlist is now currently being updated, so please check back frequently for replays of our webinars. And now I will turn it over to Lily and Cynthia. The floor is yours.
Thank you. Hey, everybody. My name is Lily Rubenstein. I am the Refugee Health Nurse Consultant with the Minnesota Department of Health Refugee Health Program. I'm going to get things started, and then I'm going to turn it over to Cynthia about halfway through. We are going to be, next slide, sorry. So our objectives, we're going to be doing a pretty high level overview of refugee health in Minnesota and then talk about how it relates to your work at healthcare homes. Describe the health journey of a refugee newcomer, understand some of the challenges that affect their ability to be healthy, and talk about lots of resources that will hopefully help you in your work in advancing health equity for all your patients, including newcomers. Next slide. All right, so I'm going to give kind of a background to the refugee health journey as well as our program. So I'm going to go through these slides pretty quickly, but you'll get a copy of the PowerPoint after, and then I'm going to hand it over to Cynthia, who's really going to get a lot farther into kind of how you can apply this to your work. We are at the Minnesota Refugee Health Program, the Minnesota Department of Health. Our mission as a program is to promote and enhance the health and well-being of refugees. So pretty big mission there. To do that, we work closely with local public health and clinics across the state to coordinate what we call a refugee health assessment, which we'll talk about more in a little bit. We do a lot of data and epi work. A lot of it is linked to on our website. If you are so interested, just look up Minnesota Refugee Health Program and you'll see lots of information about refugee and refugee health in Minnesota. Identify health disparities and provide support to impacted communities. Train health professionals. We do things like this. I work a lot with our clinicians and local public health nurses who support refugee health. And then strengthen partnerships to exchange best practices in refugee health. Next slide. Okay, so really quickly, a little disclaimer, definitions in health. There are a lot of reasons that people leave their home and a lot of reasons people flee their home for humanitarian reasons. And a lot of those reasons may be similar, but groups have different health journeys before and after resettlement. And a lot of that can be dependent on the immigration status they have when they arrive in the United States. So these journeys really inform what healthcare has been received. This includes before and after arrival, so things like immunizations, chronic disease management, etc. Certain exposure to trauma and diseases. Someone who comes to Minnesota via the Darien Gap through Mexico is going to have a really different exposure profile than people who come through, let's say, their country to a refugee camp in Eastern Africa and then come here via plane. And then eligibility for healthcare services after arrival, which we know is a huge piece of people's ability to be healthy here in the United States. So our group, the Refugee Health Program, primarily works with refugees and other groups, which we'll talk about shortly, who are eligible for benefits to the same extent as refugees. But we are always here to kind of assist with other newcomer groups. There's a lot of clinical overlap, obviously. So please reach out to us with any questions about kind of any newcomer health related item. Next slide. All right, so sticking on this kind of definition statuses piece for a minute to ground us within the US at any given time, there are citizens and non-citizens. In that non-citizen category, we have immigrants, non-immigrants, and folks who lack a formal immigration status, or what we sometimes call undocumented. Our group here at the Refugee Health Program, again, primarily work with this group in the red circle here. So these are certain immigration statuses, fleeing from persecution, and they are usually eligible for refugee health assessments and other federal benefits. It is a complex world we're living in right now, as you can imagine, and newcomer resettlement with benefits. So we're going to speak in kind of broad strokes here and not get into the nuts and bolts, but we're always happy to do that if you so please, if you reach out to us individually. Next slide. All right, so immigration statuses, refugee and asylee have the same definition. Refugees are given this designation overseas. Asylees are given this designation generally while in the US, can be given at a port of entry. So someone outside their country of nationality who can't return because of persecution or a well-founded fear of persecution on these specific categories: race, religion, nationality, membership in a particular social group, or political opinion. Some of the other groups that we work with who have benefits to the same extent as refugees include certified victims of human trafficking, special immigrant visa holders. This is a special designation given to Afghan and Iraqi individuals who provided support to the US while abroad. Next slide. Cuban Haitian entrant, that last one, provided to newcomers from Cuba and Haiti. Humanitarian parole is a really, really complex status right now. Had we been giving this talk 3 years ago, this would have taken a lot more front and center, but because of some recent changes, last slide, sorry. We're seeing less and less folks coming to the United States under humanitarian parole, and this status is actually ending for some groups soon now or closely in the future. Next slide. Okay, so benefits. When we talk about kind of these benefits that refugees are eligible for, and this is current as of right now. Again, there's lots of changes coming down the pipeline. One is medical assistance. So refugees are eligible for medical assistance as soon as they get to the United States, as long as other eligibility requirements are met. So they still have to have income requirements met and residency requirements met, which most refugees do. So the majority of folks we welcome are on medical assistance right when they arrive. A refugee health assessment, which we'll talk about. Services from the DHS Resettlement Network for up to 5 years after arrival, which we will also get into. And then certain public benefits. There's some cash and food benefits that they're also eligible for. Next slide. Okay, so we are not going to go through this slide, but just to know the refugee resettlement process is long and involved. Again, things are changing. This is not how the resettlement process looks these days for a lot of people, but this is how it has traditionally looked and how it may look again. Back. So this process for a refugee can take anywhere from a couple years to decades to someone's kind of whole life until you see them. So by the time you're working with someone in clinic, they have maybe been going through this resettlement process for a really long time. And they're a very highly vetted group, lots of security, biometric screening, and then also some health screening, which we will talk about. Next slide. So we're going to go through kind of 3 primary parts of the health journey. So the first one is called the overseas medical screening or overseas medical exam. Next slide. This is an exam that happens 3 to 6 months prior to departure. Done by a panel physician or a physician designated by the U.S. Embassy overseas. It is according to CDC recommendations, so no matter where a refugee is coming from, their exam should look fairly similar. During this exam, vaccinations are offered and people are screened for conditions of public health significance or any condition that would make them a danger to themselves or others. during or after travel. So this includes things like active TB, syphilis, gonorrhea, leprosy, disorders with harmful behavior, etc. They're also given presumptive treatment for intestinal parasites and malaria. Of note, immigrants, a whole nother category of newcomers, also undergo this exam, but they are not given that presumptive treatment. Next slide. So from a really high level overview, the amount of refugees that we welcome in the United States every year is set by the White House. So as you can see, it really waxes and wanes based on who our current president is. During the Biden administration, the refugee ceiling, which is the white bars, was increased to numbers that we hadn't seen for a very long time, if ever, to 125,000. Because of a lot of capacity constraints that happened when that refugee ceiling was a little lower during the first Trump administration, it was a challenge and a busy couple of years trying to ramp back up to make sure we were able to welcome as many refugees as possible. So we had a super busy and lovely 2024 where we were able to welcome just over 100,000 refugees as a country, which was a great landmark. 2025, that number you see there were really refugees that traveled. This is fiscal year, so traveled kind of the end of 2024 and then the beginning of 2025 before that January 20th day when the refugee admissions process was really paused overseas. So we've seen much less arrivals recently, but we're hopeful things will kind of start back up again soon. Next slide. Honing down into Minnesota, so kind of same thing, the amount of people that we welcome to Minnesota really waxes and wanes based on what that refugee ceiling is, our local capacity, and communities that are already established here, and whether their family is coming here to join them. So you can see kind of the populations we welcome each year really change kind of based on what's going on in the world. The last couple of years have really been informed by being super busy, which has been nice. And then also crises in Afghanistan and Ukraine. So we welcomed a lot of individuals under that humanitarian parole status that we talked about from Afghanistan and Ukraine, as well as the communities that are pretty established here in Minnesota. Folks from East Africa, folks from Burma or Myanmar, and newly some increase in arrivals coming as refugees from Latin America and the Caribbean. Next slide. This is a little breakout for a long period of time in Minnesota. This probably won't surprise a lot of you who have been here for a couple of years, but Minnesota just welcomes a super diverse group of refugees, as you can see. This is 25, 35, 38 years of data. It's quick math, if that's right. And that other category is huge. So we are just super grateful here that we have the opportunity to welcome people from all over the country. We have very, very large diaspora populations here in Minnesota, a good place to come. Next slide. Okay, as far as where refugees settle in the state, some of this is dictated where they maybe have family members or friends. Some of it is dictated by where the resources are, and some of it is about housing availability. So we see the majority of refugees to the bottom half of the state, as you can see, the metro area, our colleagues in Stearns County, where St. Cloud is, and then also Olmsted, where Rochester is. Next slide. Okay, moving on to the domestic refugee health assessment. Next slide. So this is a visit that is offered nationwide to new refugee arrivals per the Refugee Act of 1980. So it is mandated by this act that each state who welcomes refugees has an infrastructure through which a refugee can get this refugee health assessment, sometimes called a domestic medical exam, a comprehensive health assessment. Like the overseas medical exam, it is based on CDC recommendations formulated by a panel of subject matter experts. So this is not kind of a Minnesota specific thing. This is countrywide. This visit includes additional immunization review and update, infectious disease screening, lots of labs. Oh, last slide. Lead, mental health, vision, and hearing screening, and then referral to ongoing primary and specialty care. The really important thing about this visit, it is meant to be the first step in someone's ongoing journey with the U.S. healthcare system and just consists of what we know are best practices for people that have gone through the journey of a refugee. We monitor the results here at MDH, and we share aggregated data with our federal partners. Next slide. Okay, so this is a super high level overview. Local public health is the main thing to know. It makes all the magic happen in your local areas. So Here at MDH, we kind of have this big picture thing. We make sure that infrastructure is working throughout the state. We receive medical records from the CDC that oversees medical exam. We receive demographic information from whoever is supporting the refugee here on arrival, whether that's a private sponsor, a resettlement agency, etc. And then we match that information. We send it to local public health in the county of residence where the refugee is living, who then coordinates that refugee health assessment with the local clinic. The clinic then actually performs the refugee health assessment and then generally provides ongoing care to the arrival, kind of per their capacity allows and client preference. Next slide. So the refugee health assessment clinics, some of you may be familiar with this and may even perform them at your clinic. And this is not something that a special clinic needs to do, and the provider performing them does not need a special license. D, PA, NP, often registered nurses play a really big role in these visits as well. So here in Minnesota, we have a network of mostly family medicine clinics, some public health clinics as well, that have expressed interest in performing these visits and have received training from MDH, usually me, usually about an hour. It's quick, and then ongoing support as needed. The clinics can be FQHCs, they can be standalone private clinics, or they can be members of a larger healthcare system. Next slide. So this is a map of our assessment clinics for the last couple years. So you can see we have this very lovely, huge network. I have it zoomed in on the metro there so you can get a feel. I'm gonna really quick pull up my notes. We are lucky enough to work with a lot of healthcare homes to do refugee health assessments, and Cynthia will talk about why that makes us so lucky. So if you access Health Marshall and Worthington, Alina Clinics, Shakopee, Coon Rapids, Eagan, St. Michael, West St. Paul, Centricare, Long Prairie, Plaza Pediatrics, Sartell, Southway, M Health Fairview, Elk River, Bethesda, Smiley's, Roselawn, Neighborhood Health Source, and plenty more. Next slide. All right, so a little bit more about screening. So in Minnesota, part of our pride and joy is that we have a very, very high screening rate. The screening is not mandated from an immigration standpoint. So if someone doesn't have the screening, there's no kind of implications for the refugee status. They're still able to apply for permanent residency and become a citizen, but it is very highly recommended. And in general, people want to get the screening, right? It's a great way to establish healthcare. There's ongoing support. So we are just very proud. We generally have screening rates 95 and above, pretty close to 100. Next slide. All right, so a little bit about just kind of the clinical results of the refugee health assessment. These results will look pretty different, as you can imagine, from year to year, depending on the populations that we're seeing and kind of the specific epidemiology of the country that they're coming from, age, etc. The TB of note here is almost exclusively latent TB. So the TB that isn't contagious, isn't causing symptoms, but is good to catch so you can treat it. So it doesn't even turn into active TB as it sometimes does in people. Hepatitis B, parasitic infections is another thing we screen for, and that's a great example of why the refugee health assessment is so important. It's not something that's traditionally looked for in your kind of routine physical, but we know for folks who have been in areas where there are higher prevalence of parasitic infections, we want to make sure we're testing and treating. STIs, lead, hemoglobin. Some populations have higher levels of anemia or hemoglobinopathies. And then, very importantly, mental health screening. Next slide. All right, and lastly, I'm just going to really quick touch on the adjustment of status exam before I turn it over to Cynthia, because this sometimes comes across your guys' world, even though it's not something you provide at your clinics. Next slide. So the adjustment of status exam can also be called the green card exam. Some people call it the do not open exam because it's in an envelope that patients shouldn't open. This is an exam that refugees are able to or should get as part of what we call their adjustment of status. So they're adjusting their status from being a refugee to being a permanent resident, which they should do a year after arrival. The exam can be a little complicated because it's different for refugees versus other newcomer groups who are adjusting their status. But in general, it consists of immunization review and administration. Depending on the person, there may be some additional disease screening for conditions of public health significance. The big thing for you guys to take away from this is green card shots or adjustment of status shots are not kind of different shots than our normal ACIP guidelines. The shots needed mirror the CDC recommendations. So when people maybe are coming to you, kind of talking to you about this exam, they just need to be given the immunizations that they're due for as part of their routine care. Next slide. Civil surgeons are the providers who perform the adjustment of status exam. So unlike our refugee health assessment, there is a specific designation needed for the provider that does the adjustment of status exam. They are called a civil surgeon. They have to fill out some forms and be accepted by the U.S. Citizenship and Immigration Services. This is just a resource for you to have in your back pocket if clients or patients are asking you for assistance. How to find a civil surgeon in Minnesota. So we have a list by county here. And then if any of your providers are interested in becoming a civil surgeon to help newcomers get that green card or adjustment of status completed, the process is linked to here as well. Next slide. Okay, and with that, I'm going to hand it over to Cynthia. I will still be here, so feel free to put some questions in the chat, or we'll hopefully have some time at the end as well.
Thank you, Lily. Hi, everybody. I'm Cynthia Trevino. I'm a health systems coordinator and social worker on the team. And so Lily gave us a wonderful kind of high-level overview of what our program is, what it is we do, who we are, and different clinical components of the program. So I'm going to next step into part of the program that I work in more closely, which is our medical case program, and sort of show you guys the different pieces of work we do within this part of the program, resources we have available, and then go through a couple case examples. So hopefully this will sort of wrap everything up and show you the relationship between what it is we do and what it is you guys all do as healthcare homes. Within the program, we do have a medical case, complex medical case program that we run. And so this is a program that started about 10 years ago, although work had been happening before, but officially about 10 years ago. And so this is part of what we do for individuals who arrive, who are refugees that arrive with existing medical conditions, right? And so it's a broad range of medical conditions that we see come through the program, and I'll share a list of diagnoses and sort of numbers around that in just a couple slides here. But really what we're looking at is arrivals with medical issues beyond the scope of that routine health assessment that may require additional specialty referrals or connections to more specialty care. Things that we would see include need for expedited access to healthcare services. So this could be a person that's on medication, needs refills upon arrival or soon after. They have a severe condition or multiple conditions, a lot of comorbidities. Again, that timeline to care might look different than a person without arriving without a known medical condition. We have seen some cases where people need care immediately upon arrival or again shortly thereafter. One example of this could be a person who arrives who is pregnant and needs to get connected to OB care. And really kind of the overall thing is just needing to assure connection and follow through with health related services to have a successful resettlement in the health aspect. So in that, our program creates medical care plans for each individual that arrives with a known medical condition. And we find this information, oh, sorry. I didn't say next slide, but yes, next slide. We find this information on that OME that Lily talked about that oversees medical exams. So we do receive medical records for each refugee that arrives to our state via CDC, and it's a pretty comprehensive document. And in there, again, it would include diagnoses that is known to that individual. So we use that diagnosis and that context sort of as the driver to develop a care plan. We have a template that we use in our database, and I usually put it together. There are 26 different objectives that we can choose from, and those are just objectives that we've sort of created over the years that we found were relevant or necessary in really helping people reach some of those healthcare goals. The goal is to complete the objectives and close that care plan out within that first 90 days of arrival. So we start working pretty quickly to sort of get these pieces in place. The objectives are not implemented by our program alone. We would never be able to do all that wonderful work. So we do work closely with resettlement agencies, local public health, as Lily had mentioned, clinics and our clinical partners, sponsors, which would be sponsors arriving refugees, be it a family member or stranger, I guess, if you would, that sponsored a family over. Of course, our program has a role, and then community health workers. Some examples of those objectives I've listed here. Again, we have like 26 to choose from, but these are some of the more common ones. So very soon upon arrival, and we have timelines sort of in place for all of these things to be completed. I won't get into the full details of those, but usually within that first 3 to 5 days of arrival, we do ask the families or their case managers or whoever might be working with them to submit application for medical assistance or MNsure. Know that's going to be sort of a huge part to getting them into care, especially specialty care. We may request from our clinical partners to move up a screening appointment. So typically we like to get people in within the first 30 days for that first screening appointment, getting everything completed within 90 days. Maybe we do ask that they be seen sooner for the assessment, or we would establish a separate visit for primary care. Urgent referral to specialist, that's not something that's uncommon if a person needs specialty care. Again, urgent referral, we do the best we can, right? Obviously, there's constraints within the system. If there's a specialty like pediatric neurology that's scheduled out 4 months, we lean on our clinical providers to make an assessment on, is this an acute issue? Can they wait the 4 months? What might that look like? Assuring home health services is another objective, completing health orientation. So historically, health orientation is a class that all refugees, or a training that all refugees receive from their resettlement agency, sort of orienting them to the healthcare system in the US and in specific Minnesota, and then maybe more specifically to the community that they've moved into. Referring to intensive case management, which is a resource available to refugees. And then that overarching goal is, has this person achieved independent access to care? Again, a kind of a big thing to do within 90 days, but it is what we're kind of working towards. Next slide. So as I had mentioned, on that overseas medical exam, we get the information that helps us sort of see the full picture, who this person is from a health perspective. These are the top 10 medical conditions that we see refugees arrive with, and that is refugees from around the world, be it Western Hemisphere, Africa, Asia, all the places. So hypertension, diabetes, pregnancy, and asthma are our top 4. The data here is for 2023 and 2024, but I can tell you, going back to 2015, when we started collecting that data, it hasn't really changed. Other conditions, seizure disorders, developmental delay, HIV, thyroid disease, PTSD, anxiety, and then a whole list of other conditions that people arrive with. Next slide. So this slide here kind of gives you an idea of what it is our refugees go through in those really early days of resettlement. And I want to point out, this is just from the health lens. Obviously, that is the space that we all work in, be it healthcare or public health, but does not include other aspects of resettlement that is also happening simultaneously, which could include things like employment, school enrollment, housing stability, public benefits, signing up for other public benefits. So this is just the health aspect, but it kind of gives you a rundown and a visual to show that refugees are very busy in the resettlement process. They're very involved in the day-to-day and what happens. They look to people that they trust for support in navigating, and it can be a lot. Within the first few months of arrival, a lot of refugees may have navigated many of these things listed here, and then, like I said, a lot more outside of the healthcare realm. Next slide. All right, we'll go into some, we say challenges and resources. There's a lot of resources, a couple of challenges that I'll kind of highlight, but next slide. So this is just a data slide we wanted to put in here to lead into what our resources will be around language. As you can see, this pie chart, which is, I think, very beautiful, shows that in Minnesota, we have a huge diversity of spoken language amongst our refugees who arrived to our state. There's the big ones highlighted: Somali, Karen, Hmong, Oromo. But if you look at that other category, that accounts for 5,376 people, or 12% of the population of refugees that have arrived to our state between 2004 and 2024. And that other is listed there on the bottom right. Those are all of the languages included. We might be missing a few, but you can see that the amount of languages spoken by people who arrived to our state as newcomers is very broad. So that's sort of the laying the groundwork. Next slide. So in that, recently, our team came together and put together a directory that we call Language Ref. If you're familiar with our material, we have a couple different tools or resources that have that ref, which actually I used to think stood for reference, but I think actually stands for refugee, but however you want to think about it. So Language Ref is a directory with interpreter vendors that one of our team members in particular, actually Catherine, I'll say her name, thank you to Catherine, spent a lot of time researching interpreter vendors for rare languages. These are languages that are not commonly spoken in the United States. It is some of those languages listed on the previous slide in that other category, right? There's just a small number of individuals who speak the language and even a smaller number of individuals who are bilingual in that rare language in English who then become interpreters. The vendors are from across the United States. The website is there. This is live. You can go in and kind of take a look, play around with it. There's a couple different things you can do. One, you can obviously go in and look for, let's say you have a client who speaks Sango, which is a language that I learned about in the past year. It comes from the country in specific that I was thinking of as the Central Republic of Africa, but kind of that central region of the continent of Africa. It's a language native to that area. And so we had a family that arrived to our state that spoke the language, and we were having a hard time finding an interpreter. And we did end up finding an interpreter for the family or a couple, which included people who were out of state. But that's just one example. So you can go in there and look for a language that you're looking for specifically. You can also request. So if there's a language that's not in the directory, but you have patients or clients that you need to find that language interpreter for, you can submit a request to us and we'll do some research and try to come up with as many resources as we can. Yeah, so that's one resource that's available to you all, and it is on our website, but it'll be in the PowerPoint when it gets shared out. Next slide. I know in the healthcare setting or the medical setting, I used to work at the clinic, language accessibility and interpreters is a big deal, right? You can't function a visit or really give people high quality of care if there's a language barrier there. So these are just additional resources that includes different laws and policies and rights for patients, your clients around language access in the healthcare setting. Again, limited English proficiency things. There's statute, if you like to read statute. I don't, but it is there if you want to become more educated on sort of what the law says as it relates to Medicaid or maybe other insurances. And then just a couple additional resources. Next slide. Another big thing that we like to talk about in our program is the patient education aspect, right? So from like a public health lens, how educated is this community on maybe their own health, how educated are the provider or support people serving the population on aspects of refugee health. So a couple different things on this one. Here at MDH, we actually have a Center of Excellence in Newcomer Health. So this is a part of our program that exists. It's a huge resource for our clinical providers. There's a lot of information on the website. There's resources, tools that people can use. So that's within our program, the Center of Excellence in Newcomer Health. Another resource is the Migrant Health Initiative, which is a task force, and they have a lot of client-facing or patient-facing health education material. And then a couple other resources include Health Info Translation and the Society of Refugee Healthcare Providers. Next slide. This is a new health education that we have available specifically for newcomers, and we're actually looking to you all and others in community to sort of help spread the word. So this is called NEW. It's our Newcomer Education for Wellness. And what this is, or what these are, short videos that help provide health education in multiple languages. People can subscribe, I guess I'm going to say subscribe to it, right, to receive these text messages, and they send out videos based on different topics. So currently our topics include interpreter services, healthcare facilities, dental and health vision, stress management, and healthy eating. And so I forget the exact frequency and when they're sent out, but I think it's like on a weekly basis. I actually subscribe to it just as a test. So it comes to my cell phone as a text message. And I've gotten like 3 of the videos. The languages offered are vast. So we have Arabic, Burmese, Dari, English, French, Haitian Creole, Karen, Pashto, Somali, Spanish, and Swahili currently at this time. So those are the languages we have. And the text message gets sent to the newcomer or the person who is subscribed to it. and the language they select, and the video is also in the language they selected, which is pretty cool. So if this is something you're interested in, again, the flyer's here, but you can also reach out to us and we can send it to you in an email. Next slide. Okay, so Lily talked about this just a little bit. So some more support for refugees after arrival. In Minnesota, we're really fortunate to have our resettlement network services. So this is a network of services that is offered through DHS, or Department of Human Services. They have a refugee program over their office, rather, that's called the Resettlement Programs Office. They're the folks that sort of set up the landscape of resources specific to refugee and other ORR populations within our state. So lots of different things that you can refer clients to. One of the key things to know is that, you know, when refugees arrive to our state, these resources are readily accessible to them, but they're also accessible and available to them up to 5 years after arrival. And I think that's an important part. Sometimes different needs emerge at different points in a person's resettlement journey and process, and it could be 2.5 years into their time here in Minnesota or in the US that maybe a specific need arises, and they're still able to access these resources up to that 5-year mark. So some of what's available includes community workshops, employment and career supports. So if you're working with a family that an adult in the family has indicated maybe they had a job, they lost a job, they're in job transition, and they would like support in stabilizing that or looking for something new, they can be referred rather to the Employment and Career Supports Program. There's family education supports, family resource connectors. I have this one and the next one bolded. So family resource connectors really help with a wide variety of psychosocial needs. And so again, if you're working with a family that says they need help getting their kids registered for school in the fall, or they're looking for maybe housing support, right? They have to move, their lease is ending. They're not really sure where to start. They need support connecting to additional transportation services, whatever the need might be. The family resource connectors are really a great resource to refer that individual or family to, because what they're going to do is kind of like a psychosocial assessment, I would call it. They call it a family wellness inventory. And so they're going to do this assessment with the client or the family to look at all the areas that they might be able to support in and create kind of like a focused care plan to achieve some of those goals. Community Health Worker Solutions is also another organization that's within the resettlement network. They have community health workers that can connect with patients or clients individually, one-to-one. They do home visits, they meet people in community. Of course, their focus is going to be a little bit more health-centered. You know, maybe they're working with someone who is newly diagnosed with diabetes and they just need more education around what does that mean? What does that look like? They've received instructions from a diabetes educator, but now they're in their house. How are they storing their insulin? How are they checking their blood sugars every day? They're not clinical providers, but they do a lot of health education in that way. So, and then another big one, especially in the current times, is immigration legal services. So that's a huge branch of the resettlement network services at large. The link is there. It's pretty easy to navigate. It is set up as what we call a one-stop shop, meaning if a family connects to immigration legal services, they're going to do that family inventory to kind of look at the needs broadly. And if they see that there is a health need or there's an employment need, they're going to refer to someone else in the network for that specific service. So next slide. All right, healthcare homes and refugee health. So how do we kind of work together? What is it that kind of marries our two programs together? Full disclosure, I used to work at a clinic. I was a social worker and we were a healthcare home. So I see their relationship pretty clearly, but just to kind of lay it out a little bit more. So care coordination best practices. These are specifically in my role, like for the refugee population, but honestly, I think they're very universal from a care coordination perspective. So one of the biggest things that we see in the success of refugee resettlement in their healthcare journey is strong communication amongst the teams. And really that includes the client at the center of the conversation and their support surrounding them. That could include the resettlement case manager, it could be a sponsor, it could be nurse or social work coordinators they're connected to at the clinic, which might be you all, specialty providers, etc. The list goes on. Creating collaborative scheduling from the transportation piece to primary care to specialty appointments. Again, in that first 90 days of arrival, our refugees are very busy people. They have a lot going on. If they have a healthcare need on top of that specifically, it's just going to sort of compound to what it is they all have to pay attention to. So when the team is together, being as collaborative as possible, honestly, it creates a lot more successful outcomes for the individual and their family. And then a big piece of the work also is empowering the newcomer that they are at the center of their cares and they can and should drive their health outcomes, right? Of course, that comes with a lot of support, a lot of health education, a lot of health system navigation, education. The healthcare system in the US is very complex, as we all know. A lot of moving parts from the insurance to the transportation to the specialty care, and just really assuring them that we're here to help. We have the tools, we have the resources. One of the clinics, Lily read off a whole list of clinics across the state, but one of the clinics that is local to the metro area is the mHealth Fairview Clinic Bethesda. I was looking at the list of attendees. I didn't see anyone from Bethesda, but I think I saw maybe a former Bethesda person. I won't call them out. So they're a certified healthcare home. Their nurses and social workers have a high level of coordination directly with their patients. They communicate closely with their external team members. They are one of our screening clinics, while they also do the refugee health screening. They do establish people for primary care and have served some of our highly complex medical arrivals as well, which has been wonderful. One thing that Bethesda does really well is utilizing culturally relevant resources available right in their community. So they're a clinic sort of their community in the community, and they're really well connected to the cultural resources around them as well. All right, next slide. Okay, just a few more slides here. We're going to close out with a couple case examples. I always feel like when I'm talking at people, it's like, this is a lot of information. Like, what does this look like in real life? Like, how does this actually play out? So just a few case examples here that I'll share that kind of give a timeline, an idea of how does this overseas exam work? How does this refugee screening work? How does getting connected to specialty care, how does that actually look? So in this case, we have the Mendoza family. They arrived on November 1st. They're a family of 4. They were welcomed and supported by a local resettlement agency, which was the International Institute of Minnesota. 2 days after arrival, we at MDH received that overseas medical exam from CDC, and we're able to see that mom has diagnoses of hypertension and diabetes, and she has prescribed 2 medications. About 4 days post-arrival, the International Institute case manager helps the family apply for benefits, including submitting a MNsure application. So that's to get that health insurance piece in place. On November 20th, mom has her first medical visit in the United States at Bethesda Clinic. At this visit, her chronic conditions are addressed. So she has been diagnosed with both of these diagnoses for several years, but needed to discuss medications and just sort of symptoms post-arrival. So that part is taken care of. In that time, they were also able to start some of her refugee health screening labs. So she has a leg up on that initial refugee health screening appointment. About 30 days or a month after arrival, the whole family completes their first visit of the refugee health screening process at Bethesda Clinic. And then about 2 weeks after that initial visit, they actually have their second refugee health screening. So I think Lily may have mentioned this, but a lot of our clinics operate on a 2-visit model. Not all, some are able to do it in one. But in this case, they had 2 visits to complete that refugee health screening. They completed it about a month and a half after arrival, the full screening itself. From there, the children are future scheduled for their well child checks, which is, again, a separate physical, as you all know. Mom has now established a relationship with her provider at Bethesda, so she's been to the clinic 3 times at this point, is getting pretty familiar with the staff there, is feeling more comfortable in the environment, and decides she wants to continue her primary cares at Bethesda Clinic. Next slide. All right, this family, a little bit different scenario. So this is the Farah family. So we're actually going to go back a little bit before they arrived. So they also arrived on November 1st, but we started hearing about them at the MDH Refugee Health Program before they arrived. So on about October 15th, we had received notification from a local sponsor of their family members arriving with high medical needs. And so the sponsor didn't have a lot of detail and certainly didn't have those overseas medical records. So we were able to reach out to our partners at IOM, which is the overseas physicians who complete these pre-departure screenings, to gather more medical information about the client's condition and what the needs might be upon arrival. And we find out there's a 10-year-old child in the family with cerebral palsy and epilepsy. After we received those medical records from the overseas physician, we reached out to some of our local clinical partners that included Bethesda Clinic and Gillette Children's to begin talking about sort of coordination of care, seeing if we can get some appointments on the books in advance in anticipation of the family's arrival. The family of 5 does arrive to Minnesota on November 1st. They're welcomed by their family members via the sponsorship pathway, which is how they arrived. They apply for healthcare benefits within that first about 10 days. And the child is actually set up with an appointment with the Complex Care Clinic at Gillette Children's on November 12th. That is their first interaction with the healthcare system in the US. The parents are highly anticipating this. The child has a lot of medical, physical needs and just didn't have any of the equipment overseas at the refugee camp. So they're really looking forward to getting him a proper wheelchair and different things like that. So they have that appointment, needs are assessed, and then the future appointment scheduling starts, which you can imagine it's quite a few visits the child will have. Following that appointment, the family completes their first screening appointment at Bethesda Clinic, and the kiddo, the 10-year-old, establishes with the primary care provider at that time as well. The sponsor helps the family enroll in a local school district, which for this child is a big deal and may require some additional assessment just to have proper placement within the school system. And then about a month and a half again after arrival, the family completes that second refugee health screening visit. All of the children in the family are future scheduled for well child checks or well child visits. And then there's a connection made between the Bethesda Clinic social worker and the Gillette Clinic social worker, just to make sure that future appointments are being coordinated sort of in tandem, in communication with each other, so there's not duplication of appointments or overlap, and people are clear on what their roles are going forward with coordination. So those are 2 case examples. I would say the first one is a much more common sort of case example that we see of a person arriving who's otherwise fairly healthy, but does need to be seen for some chronic conditions, med refill. The second example, we certainly have people arrive with that higher level of need, but it is a smaller percentage of the larger medical case number. Next slide. And that is it. We are at the end of our presentation. This is our contact information, our website. If you haven't checked it out, please do. There's a lot of information on there. We have a direct phone number, and then we have a shared email box that we do monitor very closely. If you have any questions that come up, feel free to reach out. And that is it. I think we have time for questions. So
We do. We have lots of time for questions. So please
perfect.
feel free to put them in the chat. As they are doing that, I'm also going to encourage people to, and we'll have this contact information on the follow-up email as well. I'm also going to encourage people to complete the survey. This helps us plan for future webinars, and I'm going to put the link in the chat as well. Lots of good thank yous online here for you both, ladies. Thank you. So, so the biggest thing is if any clinic has any questions about conducting, having a new refugee, that maybe the best thing would be to contact you guys via telephone or email kind of thing, if they have one that they might be made aware of.
Yeah, absolutely. And what's good to know, and probably doesn't need to be said with this group, but asking someone their immigration status is not something that often is appropriate in the clinical setting, and it's certainly not a precursor for you reaching out to us. So you can just share, I have a patient, they were born in this country, and here's some kind of broad information that I know about them, and then ask your questions. And if it's something that we need to dig into a little bit more for various reasons, we can talk about that together in what's the appropriate and safe way to do that.
Wonderful. And Lily, you put all the contacts in the chat, and I will also put those in the email, in the follow-up email as well. So don't feel like you have to copy them down, anybody, but I'll make sure they're in the email as well. Yeah, any questions, please feel free to put them in the chat. We'll wait just a couple more minutes here. Anything else that you ladies can think of that might be? Your presentation was incredibly expansive, so I really appreciate it.
It's a lot of information. It's a complex world and only getting more so. One thing I think we like to share with especially our clinical partners is if you are seeing gaps in especially patient education or things like that, and just let us know. We have certainly capacity usually and resources to help with things. A lot of the resources that Cynthia shared are direct kind of things that we developed because of feedback that we received from clinics about, translation problems, etc. So just reach out and say, you know what, I can't find anything about this. Can you help, or put it on your list? And we're happy to do that.
Wonderful. You ladies must have answered everybody's questions because nobody has any questions at the moment. If they do, we'll put them in contact with you, or they can email you guys directly. And I thank you again for your participation in today's webinar on refugee health in Minnesota. We've hoped you gained invaluable insight that you can apply in your practice right away. And Cynthia and Lily, thank you so much for presenting today. And we look forward to having you back again soon.
Thank you.
Thank you.
Thank you. Have a great day, everybody.